So we're right on time, to be honest, and we will continue with the next presentation.
Okay, thank you very much for a good presentation. And we are going on, and next our lecture from Evgeny Markosyan from Moscow, raise with fans, please.
So, I will talk in English, but first of all, у меня вопрос к технической службе. Я скажу, когда запускать видео, и, пожалуйста, если можно будет чуть потише, потому что там есть сопровождающее фоновое видео. So we move on to the next topic, and today I'm going to present a case of fans, RIRS with fans. But first of all, I would like also to share and express my warm words of gratitude to all people who were involved in the process of putting together such a wonderful Congress. And also it's a great pleasure to be here in such a hospitable city as a Tashkent. So it's always my pleasure. So this is the case is about the RIRS with fans, and actually I would call it unofficially the fans. Is it an easy peasy surgery or not? Of course, to highlight that great and dramatic transformation that our retrorenal surgery, retrograde intrarenal surgery, has undergone during the last decade. So please run the video, and we will proceed with our patient. And our patient, as you can see, the video is running. So our patient is a 70 years male with a 5-year history, with a history of stone episodes. So he already has been twice operated. So he had 2 PCNLs, and the recent PCNL has been performed just 1.5 years ago. So he's suffering nowadays. He's suffering with the lower pole stone, which is not a big stone, but middle-sized stone. So it is a 12 millimeters long, and with a volume of almost 5 cubic centimeters. And it's quite hard, 1,400 Hounsfield units. So the patient is really exhausted with this surgery, with the urolithiasis. So he's demanding very simple, very reliable, and very minimal invasive solution. So that's why we scheduled him for this surgery for fans, and no pre-stenting was planned. Since we're using the 11 French size sheets, so which are without any obstacles, it passed through the ureter. So now you can see, this is the video of the surgery. As you can see, judging of the appearance of these stones, we might guess that this is calcium dehydrate stone, and the further stone analysis approved and confirmed our guess. So we work with the TFL laser and with the standard settings such as 1 joule and 15 hertz, knowing that all the fragments could be retrieved and sucked out from the collecting system very easily without any basketing, with no need for basketing. So it is important to mention that here we don't chase the fine dusting, and we're actually aiming at something in between fragmentation and dusting, because we understand that we can catch and swallow in the suction funnel all the small pieces, all the small particles that breaks off the stone. So we're just like letting the suction to do its job. And also we maintain a continuous suction throughout the whole procedure, which helps us to keep the visual field crystal clear, and the vision, as you can see, stay unobstructed. Here we don't care about the red repulsion, so nor do we adjust our setting for that, because as you can see, the stone is nicely fixed against the calyceal wall, and nor do we ask for apnea, for the forced apnea here, because we observe a very minor respiratory movements. Here in this surgery, we also didn't use actually the tissue sensor because, you know, it was technically unavailable. Nowadays, it's already available in our clinic, so we just obtained our UMAX laser a couple days ago, so we are just starting to widely use this option. You know, this option is about the prevention of mucosal damage, which, you know, switch your laser off once it points at the mucosa. So that's a great option. I guess using this option, we will also decrease the need for respiratory suppression during the surgery. So as the stone mass, the mass of the stone debogs, we see larger and larger fragments start to break off. And you also might notice that the walls of the calyceal cavity tends to collapse. It is also due to the pressure, due to the suction, and here we use gravity irrigation with pumping. Here the assistant plays a huge role maintaining this very, very fragile balance between the irrigation and suctioning, preventing the collecting system from, you know, collapsing. This is a huge role. So in retrieval of this, so you can see the relatively big fragments might be retrieved via your access sheet quite easily. Just similar the Bernoulli effect that we observed during the percutaneous surgery. So in this case, we also should mention that this is a huge role of the assistant because he have to. This is a very nice quest of cooperation between you and your assistant, who should anticipate all your actions and all your moves and just increase the pressure the moment before you start to pull your scope back.
Can I ask a question?
Yes, sure. Everyone is free to ask questions.
You mentioned the irrigation pressure, but can I ask you about your suction pressure?
So suction pressure, we usually work between 100 and 150 mercury, and sometimes it goes. We raise it up to 200. So actually, when the job is done, and we are hunting. What you can see here, we are hunting for the residual fragments, and we just understand that no lasering would be going on during the surgery, just the retrieval. We accelerate and step up the pressure a little bit, so we increase it.
And in a case like this, for example, if you have a stone stuck inside the access sheet, do you laser it there, or do you find it dangerous to laser?
Yes, without any doubts. Without any doubts. And as you can see here, there was a couple of examples. Yes, just like this. So sometimes if the fragment won't go, inside your scope, into your scope, so just a couple of hits with a laser would be enough to toss it up toward your suction funnel and swallow it.
But that is actually a dangerous move if you do not hit it in the center, because these access sheets are not as strong as the conventional ones.
Absolutely.
And that heat can melt the access sheet. I have seen those.
Yes, could be, but in our cases, they are all, disposable, so we don't worry about this. But
that should be a message for, especially.
Yes,
for
absolutely. Whenever you can keep on the safe side, you should keep on the safe side. I totally agree. And I guess this is the end of the surgery, and I would like to, I would like just to show how this 100% stone-free rate looks like in our clinic, in our eyes. So, the suction, it fuels your sense of perfection. And so actually in our case, it, even prolonged the surgery time, because we go on and on again and again through the whole calyces. and trying to make it absolutely clear. And sometimes, because you don't want to leave the dust behind, even if a small dust, but you know, the life shows us that the dust might be not that small as it can be expected. So, and the small fragments are found even in a very unexpected corners of the calyceal system.
Can I ask also one
Yes,
more question?
sure.
Now, everyone is talking about how good this suction is, but no one is talking about any downsides. So can you elaborate on this issue? Are there any downsides? Are there any risks, situations that we must avoid these kind of devices? Maybe there is not. I just want to get your
Yes, actually, we don't see. Of course, there is a hidden something. So let me show you. This is just a final view of the calyceal system. And actually, thank you for the question, because you're asking a very important question, because we could be in a condition of such kind of euphoria and thinks that this is a perfect solution for everyone. But we also, every time we should think about where are those shortcomings of this technology. And the first shortcoming I can mention is the fragility of this, of this access sheet that are at risk of falling apart during the procedure. So it might happen, actually. And the second one, I actually don't know the influence of the low pressure on the kidney. We know the higher pressure, the more dangerous this procedure. What about low pressure? We don't know the data on it, so actually we don't know. And the third, I would say, it's some kind, this low pressure and the suction. Again, I would repeat, so make the calyceal system to collapse. So after collapsing, we could observe some bleeding that hampers our procedures, not allowing us to continue it.
May I add one downside?
Sure.
During suctioning, sometimes this is a problem that I had. Some small fragments are stuck between the endoscope and the access sheet.
Yes.
Then you have to take all the system out and then re-enter.
It happens all the time. Because yes. So so if you're working, this is the issue of miniaturization, because whenever you have a safe 7.5 scope and 11 French size your sheet, so the gap between the scope and the sheet is bigger and is quite enough sufficient to keep it going without these kind of obstacles and this kind of problems. So I guess we're already done. It's just a few minutes left. This is yes. So this was the final view. So let me summarize. So what do we have nowadays? 100% stone-free rate, 16 to 18 minutes operative time. Patient rendered stone-free with one surgical session. So that what we really should call the easy-peasy surgery and a reliable surgery. Again, this is kind of a magic for me, the technology-driven magic. And I guess going forward will help us to extend our boundaries even broader. And I would like to say that I appreciate your attention and kindly invite all of us to our center, which is a Moscow Urology Center in a warm-hearted city of Moscow. Thank you very much.
Thank you. Before continuing, if I may, we have Peter Alkin here, and this is a new technology. Can I please ask your opinions about these new advancements, the suction? What are your thoughts about suction on it?
Yeah, I just asked Thomas Schnoll, and he was supposed to give a presentation, will the percutaneous survive? And when I look at what Vivian has shown, I think it will be hard for percutaneous to survive because of two reasons. The size of the stone is increasing that you can do by ureteroscopy, And what we have realized in our country, the more advanced the technique is developed, the patient do not fear to go to the urologist. They come earlier and they come with small stones. And what we have seen that the big staghorn stones went down, the frequency that we saw them. So at the end, small stones, ureteroscopy, and vision, perfect.
Thank you so much. Should we do a voting for the fans?
Yes, voting,
Pros and
Voting
cons.
for the fans.
vision.
So
Yeah.
we have one more question from Arman. Thank you, Professor, by the way.
Thank you, Peter.
Maybe this is a little bit of provoking question in a way, but as you mentioned, the downside of these instruments is that, and we're coming from not the West, the best developed countries, there are multiple use of these instruments. I mean, the normal ureteral access sheets, we tend to use it multiple times, at least in Armenian practice, we can use it. I believe in many centers you can still re-sterilize it and use it. But these ones, you should be more careful. Have you tried it? Have you used it in your center?
Okay, let me put it this way. Thank you for the question or your comment. Let me put it this way. They are officially single-use instruments, and officially they are used one single time. But actually, sometimes we have an urgent need to reuse them. And they're, yes, I'm absolutely true. They're completely fragile, and they're nothing to have, common with the previous non-navigable sheets, because they could be used, many times. So these sheets are really single use, because at the second time, you already putting yourself and your patient at risk of some kind of, unexpected and undesirable events, such as, the sheet breakdown inside the patient.
Professor. Yes, please, Professor.
Yeah, perfect. Vivian, I have one additional question. Thomas Knoll, he commented, when you spend 3 hours for a ureteroscopy, and this is not well paid, you're better paid by 40 minutes of percutaneous. How is reimbursement in Moscow for ureteroscopy for percutaneous?
I totally agree with you, because yes, it's a very, actual and very serious question. So when it comes to time, I mean, you have a very different attitude for the time. So now we move to the Moscow Urology Center, where something like 14 stone surgeries are planned, and I'm head of department. So my goal is to keep up with the schedule. Yeah. And I understand that time really matters. I said, okay, you should do supine, because it really saves, 10 to 15 minutes. Yeah. You have to do, in these cases, PCNL, because these save time. And additional 30 minutes, it's additional RIRS, one more patient cured. So the times really matters. So in these terms, from this point of view, actually, I agree. As a head of department, I would push my workers and my colleagues to do a faster and efficient surgery.
But how do you push the system that you get a better reimbursement for a long ureteroscopy?
So actually, we don't have this kind of reimbursement as a taxi drivers. I mean, by time. So it's not a 1 ruble per hour and stuff. So it doesn't matter how long would you operate. But if you operate long, the less patients you can include into the schedule. So the clinic loses money. Yeah, that's the point. Absolutely. So it's not, yes, the system does not inspire us to use these long but less invasive surgeries.
I think this is a very important comment, because a urologist should fight for the proper reimbursement if we save our patients with good treatment.
Thank you, Peter. I would say urologists never stop fighting.
Thank you very much.
Thank you.
For all the comments.